Hey, health warriors! Head injuries can happen in seconds, but their impact can last a lifetime. From concussions to severe brain trauma, early recognition and precise care are crucial. Today, we're walking through the types of head injuries, how to assess them, manage them, and support recovery from ICU to home. Head injuries can be closed or open, also known as penetrating, and are categorized by severity, such as mild, with a GCS of 13 to 15, includes concussions, which may involve a brief loss of consciousness or altered mental status. Symptoms often include headache, dizziness, nausea, and memory loss. Moderate head injuries have a GCS of 9 to 12. Severe head injuries with a GCS of 8 or less carry a risk for coma and long-term deficits. Common injury types include contusions, which are localized brain bruises, cerebral edema, which involves swelling and increased intracranial pressure, skull fractures that can be linear, depressed, or basilar, epidural hematomas that are arterial bleeds with rapid onset, subdural hematomas, which are venous bleeds with slower progression, and diffuse axonal injuries, which are widespread damage often from high-velocity trauma. Symptoms and diagnostic evaluation are crucial. Symptoms can include loss of consciousness, confusion, lethargy, nausea, vomiting, vision changes, unequal pupils, slurred speech, and even seizures or posturing, such as decorticate or decerebrate postures. For diagnostics, a non-contrast CT scan is the first line to detect bleeds and fractures. An MRI is better for soft tissue injuries and diffuse axonal injuries. The GCS score helps monitor severity, and it's important to watch for Cushing's triad, which includes bradycardia, hypertension, and irregular respirations, indicating increased intracranial pressure. Medical interventions start with stabilizing the ABCs: airway, breathing, and circulation. Elevate the head of the bed to 30 degrees to reduce intracranial pressure. Administer mannitol or hypertonic saline for cerebral edema and anticonvulsants for seizure prevention. Use ICP monitoring devices, such as a ventriculostomy, when needed. Surgical interventions may include a craniotomy for hematoma evacuation, or burr holes or decompressive craniectomy in cases of high intracranial pressure. Frequent neurochecks. Glasgow Coma Scale. Pupils, level of consciousness. Monitor for changes in speech, motor skills, or behavior. Maintain oxygenation and perfusion. Prevent complications, aspiration, seizures, pressure injuries, and deep vein thrombosis. Also, monitor drains, intracranial pressure, and signs of herniation. In the post-acute phase, coordinate physical therapy, occupational therapy, and speech therapy. Support emotional and cognitive recovery. Educate family on behavior, memory, and rehab expectations. Importance of follow-up care and rehabilitation. Symptom monitoring for delayed complications. Safety at home. Fall prevention and medication adherence. Mental health resources for adjustment and coping. Bottom line, with head injuries, every second counts. So does every nurse. From triage to rehab, nurses are the anchor in the storm of brain trauma, offering calm, clinical excellence and compassionate support when it matters most. Have you worked with head injury patients? What's your top assessment tip? Drop it in the comments. Subscribe and follow for more trauma and neurocare insights, built for bedside heroes. And remember, protect the brain, prevent the swell, empower the recovery.